Thank you for the opportunity to present our work on the implementation of pediatric emergency care coordinator activities across 8 states. We know that over 90% of emergency department visits by children occur to general EDs rather than to children's hospitals or specialty pediatric centers. Multiple studies have shown differences in care and outcomes between general EDs and emergency departments within children's hospitals. When we look among general EDs, those with higher readiness scores, those that are more prepared for pediatric patients, have lower pediatric mortality. One of the factors most associated with having a high readiness score is having a pediatric emergency care coordinator, a physician or a nurse who takes on specific responsibility for ensuring that the ED is ready to care for children. However, the description of the Pediatric Emergency Care Coordinator, or PEC role, as provided by the National Pediatric Readiness Project is extensive, and little is known about what tasks PECs are carrying out in practice. The goal of this study was to describe the implementation of PEC activities across 8 geographically diverse states to understand the variation of how PECs are being implemented in the emergency department. We used the 2019 National Emergency Department, or NEDI USA survey, to identify EDs with PECs in 8 states: Arkansas, Florida, Iowa, Maryland, Nebraska, New York, Vermont, and Wisconsin. States were selected for their geographic diversity, and also to select states that had high-quality pediatric AHRQ SAD-CID data, in order to set up for an eventual data linkage to be able to look at PEC variation and outcomes for pediatric patients. Each ED was called with a standardized survey. The survey asked about how long EDs had had a PEC for and how many of the NPRP recommended activities the PEC participated in, with a particular focus on quality improvement, education, verification of staff skills and knowledge, and ensuring adequate medications, equipment, supplies, and resources for children. We also asked about how many PECs there were and what type of training they had had, how much time was devoted to the role, and how that time was supported. Of the 830 EDs in our sample, 201, or 24%, reported a PEC, 167, or 83%, completed the survey, and 153, or 92%, confirmed the ongoing presence of a PEC. Of those 153 with a PEC, 81% reported that the PEC participated in quality improvement initiatives, 93% provided pediatric education to ED clinicians, 90% verified staff skills and knowledge, and 90% were responsible for ensuring medications, equipment, supplies, and resources for children. There was meaningful variation in hours devoted to the role, with a median of 12 per week and an interquartile range of 5 to 40. There was also wide variation between the states in PEC activities, with 50% of PECs in Vermont participating in quality improvements activities as compared to 100% of PECs in Nebraska. There are some limitations to our study, including that our data was obtained by self-report from administrators who were generally ED directors and not always the PEC. And we don't yet have any data to assess the association of this variation in PEC status with clinical outcomes. In conclusion, this large multi-state survey of EDs demonstrates important heterogeneity in PEC implementation and the importance of understanding the specific tasks that the PECs are completing. Future work should focus on how PEC and time and tasks may impact pediatric readiness, quality of care, and outcome for pediatric patients. In addition, work is needed to better understand which features of the PEC role are specifically most important for improving pediatric emergency. Opportunity to present our work on the importance of patient insurance status in pediatric emergency care regionalization patterns, presenting on behalf of this larger team. Pediatric care is becoming increasingly regionalized. From 2004 to 2014, the likelihood of a hospital completing care without transfer decreased 65% for pediatric patients. On the flip side, intra-hospital transfers for pediatric patients are increasing. We know from the literature that insurance status has been associated with both transfer and transfer outcomes. Regarding transfer, being uninsured or self-pay has been associated with higher odds of transfer compared to patients with private insurance. However, Medicaid patients have similar odds to those with private insurance. Among patients who are transferred, those with ED to ED transfers, pediatric patients who have public insurance or who lack insurance are more often kept for admission or observation than those who have private insurance. Another way to think about transfers across a health system or across a state is to examine the regionalization index, or the degree to which definitive care is concentrated. The regionalization index incorporates the probability of care completion across a range of conditions between 0 and 1. 0 would be a state in which patients present to all hospitals and complete their care without transfer, whereas 1 would be a situation in which patients are frequently transferred or seen in only a few hospitals. Another way to examine transfers across a system is to look at a network density, or the proportion of actual versus potential hospital connections within a network of transfers. The goal of this study was to look at the regionalization of pediatric care and the density of the intra-hospital transfer network, and to determine whether those varied by insurance status. We chose to look at New York State SAD-CID data from 2016 and focused on pediatric patients, those less than 18 years of age, with an insurance status of public, private, or uninsured. We calculated the regionalization index and the network density overall and stratified by insurance status. There were almost 1.6 million pediatric visits in New York State in 2016, and of those, 7,548 or 0.5% were transferred, and almost all of those had an eligible insurance status for inclusion in our cohort. Of the transfers, 24% were from ED to ED with discharge, 28% from ED to ED with admission, 31% from ED to inpatient, 16% from inpatient to inpatient, and 1.2% from inpatient to ED. Regarding the regionalization index, the overall regionalization index was 0.25. For privately insured patients, it was 0.24. For Medicaid insured patients, it was 0.26. And for self-paid patients, it was 0.20. And you can see the 95% confidence intervals with all of those numbers. The network density overall was 0.02. For privately insured and Medicaid insured patients, it was 0.01. And for self-pay patients, it was 0.004. Limitations of this study include that we include only a single state, and we're unable to separate out by conditions or by age, and that work is currently ongoing. Overall, despite prior work showing an association between insurance and transfers, we did not find an association between insurance status and regionalization index or network density. However, these data do show significant regionalization of pediatric care and low network density. Additional work is needed to better understand how insurance status may affect transfer decisions and destiny.
Hi everyone, my name is Grace Yee. I'm a Pediatric Emergency Medicine Fellow at Boston Medical Center, and I will be talking about my study examining how having children in the home impacts the beliefs of gun owners, a national survey. I have no disclosures. So there is a significant burden of pediatric firearm-related injury in the US. It is the second leading cause of death in children between 1 and 19 and accounts for about 20,000 pediatric ED visits annually. It's been well documented that having a firearm in the home increases the risk of injury to household members, both intentional and unintentional. And it's an estimated about 90% of unintentional childhood firearm-related deaths are due to a child playing with a gun in the home. So given this, it is extremely important to engage parents in effective firearm safety counseling, but this has proven to be historically challenging given the complex social drivers surrounding firearm ownership in the US, specifically being very polarized and politicized by the media. So the AAP released a policy statement in 2012 stating the absence of guns from children's homes and communities is the most reliable and effective measure to prevent firearm-related injuries in children. The perceptions and attitudes that surround pediatric gun safety vary widely within the community, but there has been very limited data that examines how the impact of children in the home have on gun owners' beliefs. So we aim to compare the attitudes and beliefs held by gun owners with children in their homes and those held by gun owners without children in their homes. And we hypothesized that respondents with children in the home were more likely to own guns for protection, safety, and perceived value to their family, and were more likely to favor gun violence prevention policies. So this is a secondary analysis of a survey titled the National Lawful Use of Guns Survey. This is a cross-sectional survey conducted of 2,086 respondents who were adult gun owners in the US. This was conducted in 2019 using a large internet panel and had about a 56% survey response rate. This study looked at attitudes and lifestyles held by gun owners within the US. We then took the data from this study and divided the respondents into two groups: gun owners with children in the home and gun owners without children in the home. And we analyzed this data in 2020. The variables we looked at included respondent characteristics, reasons for gun ownership, upbringing, identity, and symbolic meaning of guns, and then attitudes towards gun policies. So the majority of respondents were white, male, and living in metro areas. About half of them self-identified as Republican and considered their political ideology as conservative. About 18.4% of respondents had children in the home, and they tended to be younger, attended college, married, working, or earning greater than $100,000 a year. So the majority of respondents stated that their primary reason for gun ownership was for defense. And when asked in defense of whom, respondents with children were more likely to state to protect their family than themselves or their community. The majority of respondents felt that their neighborhoods were safe and that gun violence was not a big problem in their communities, and this was echoed among both groups. However, respondents with children in the group were more likely to say that guns make them feel safe. The majority of respondents in both groups agreed that they grew up in a household with guns and that their family members own guns. However, the overwhelming majority of respondents in both groups state that they do not identify as a typical gun owner and do not have qualities typical of gun owners. When asked about a set of values tied to owning a gun, respondents in the children group across the board were more likely to share a stronger symbolic meaning to guns. When asked about attitudes towards specific gun policies, respondents in the children's group held a greater opposition to gun control measures. This included feeling that gun laws needed to be more strict and the NRA had too little influence over gun laws. Being more likely to oppose policies limiting gun ownership, including to those deemed at high risk of violence, and being less likely to support policies that ban dangerous weapons like assault weapons. They were more likely to show support for increased firearm presence in schools while opposing restriction of concealed weapons. And the majority of respondents in both groups opposed requiring a person to lock up guns in the home. So a number of discussion points have come up from our study. First, gun owners with children were more likely to own guns to protect their family, were more likely to feel that guns kept their family safe. But despite this, they stated that they felt very safe in their communities. So this presents an opportunity for healthcare workers to dispel blind acceptance of the perceived value of gun ownership, regardless of the perceived threat. And healthcare providers should be cognizant of this discrepancy. Inconsistent with our hypothesis, gun owners with children held more conservative attitudes towards gun control measures, including being less likely to favor gun violence prevention policies and held stronger ties to symbolic meaning of guns. This points to a very deeply ingrained culture within the US that's been largely accepting conventional NRA rhetoric and can present a potentially unique challenge to engaging parents in successful behavior modification. And then lastly, we found that respondents with children did not support laws requiring a person to lock up guns in their home. This implies that parents own guns with the intention of protecting their family, but they don't actually support policies to prevent the leading cause of firearm injury in children, which is accidental. Prior educational efforts, as well as healthcare initiatives in the last few decades, have been largely centered around encouraging safe storage practices. However, this may not be the most effective approach. Some factors that were not investigated in our study include the region of the US, so local political climates or state laws, mental health, substance abuse, race, family dynamics, religion, socioeconomics, age of children in the home, so parents might feel differently about the risk of injury with having a toddler versus an adolescent, or safe storage practices or accessibility by children. In conclusion, acknowledging the motivating factors and personal beliefs which influence one's decision to own a gun is a pivotal component of educational efforts towards firearm injury prevention. Given the burden of pediatric firearm injuries, it is especially important to develop a deeper understanding of how parents' motivations surrounding gun ownership are impacted by having children in the home. We hope that these results will provide specific insight to help target individual counseling and guide community-level efforts to reduce pediatric gun injuries. Thank you.
Hello, my name is Ann Runkle, and my talk today discusses the project Impact of a Statewide Protocol Change on Prehospital Management of Bronchiolitis, a Pre-Post Analysis. I'd like to thank my co-authors Matt Scholl, Tanya Strout, and John Martell. My project focuses on bronchiolitis, which is a pediatric illness caused by viral infection of the lower respiratory tract. It's a very common cause of respiratory distress in children less than 2 years old and is the leading cause of hospitalization for infants. In the past, we often attempted to treat bronchiolitis with bronchodilators and other medications, despite no strong evidence that they changed clinical outcomes. In 2014, though, the American Academy of Pediatrics released a practice-changing clinical practice guideline for bronchiolitis. This evidence-based guideline recommended that bronchodilators, steroids, epinephrine, and nebulized hypertonic saline not be given to patients with suspected bronchiolitis, and that treatment should focus instead on providing suction and oxygen as needed. At the time, the main state EMS protocols routinely recommended albuterol for all pediatric patients in respiratory distress with wheezing on exam. Based on the AAP guidelines, the main state EMS protocol was updated to explain the pathophysiology of bronchiolitis and specifically recommend against the routine use of albuterol and steroids in wheezing patients under the age of 2. This protocol was updated on July 1, 2015. As part of the standard protocol change rollout to the many dispersed EMS services in Maine, this change was accompanied by in-person and online education sessions, FAQs, and other educational materials. My project analyzed the effect of the protocol change on pre-hospital treatment of pediatric respiratory distress. This was a pre-post analysis using the statewide EMS database. We were able to obtain data from the 18 months before and after the change. The main EMS database was reviewed for children under the age of 2 with a respiratory chief complaint. This was then refined for patients transported by EMS from the field to a receiving hospital with free text EMS history or exam elements supporting a diagnosis of possible bronchiolitis. Based on review, we excluded other causes of respiratory distress such as croup, anaphylaxis, choking, brief resolved unexplained event, asthma, trauma, seizure, and tracheostomy malfunction. We used a chi-square analysis to evaluate management pre- and post-protocol change. We hypothesized that oxygen use would not change, as it was recommended both before and after the protocol change, but that bronchodilator use would decrease. Instead, we found that while oxygen use did stay unchanged, bronchodilator use also remained unchanged. There was no significant change in the proportion of these children receiving bronchodilators in the pre-hospital environment. This finding was unexpected but not surprising. Our sample size may simply have been too small, or the study time period may not have been long enough to detect a difference in practice. Our findings, however, are consistent with other studies in the literature demonstrating long gaps between when new research is published and when it actually becomes standard practice. In the case of children with bronchiolitis, removal of albuterol from EMS protocols may also be complicated by provider and family desire to do everything for acutely ill children. Further research is necessary to determine why this protocol change did not change patient care.
Thank you for having me. My name is Regina Toto. I'm one of the Pediatric Emergency Medicine Fellows at the Children's Hospital of Philadelphia. And today I'm going to be talking to you about augmented reality and pediatric septic shock simulation. Sepsis is a leading cause of morbidity and mortality in children worldwide. And one of the main ways that we teach people how to recognize and manage sepsis is through simulation. Recently, augmented and virtual reality have been explored both as adjuncts to simulation and also as independent learning modalities. Augmented reality refers to superimposed digital media on the real-world environment, as opposed to virtual reality, which refers to an immersive virtual world. One of the main advantages of augmented reality is that it allows participants to actually utilize real-life equipment while viewing digital media. This enables them to receive real-time feedback that they wouldn't otherwise receive during simulation. One of the main questions that we were thinking about when we conceptualized this project was, can we utilize augmented reality to enhance a septic shock simulation? Our aims were as follows. We wanted to develop an augmented reality pediatric sepsis training system. A term we coined for this was PediSepsis AR. Specifically, we wanted to create a digital model of circulation that expanded as IV fluids were administered. And we aimed to create this application for the Microsoft HoloLens, which is a head-mounted display. We wanted to test the feasibility of collecting data on timing and volume of IV fluid administration during the septic shock simulation while using augmented reality. And finally, we wanted to describe PD Sepsis AR as an educational tool. I'm going to give you a visual of what PD Sepsis AR looks like in action. So as you can see, this is a digital model of circulation that expands from a proximal situation initially to become more peripheral. So what happens is, as participants administer boluses of IV fluids, 20 cc's per kilo, 40 cc's per kilo, and finally 60 cc's per kilo, the circulation incrementally expands until finally all of the most peripheral blood vessels are perfused, including those going to the brain. We designed this study as a randomized controlled feasibility trial. So all participants were randomized to the PD Sepsis AR or control groups. Those randomized to the PD Sepsis AR group wore the HoloLens and got to see the digital model of circulation overlaid on the simulation mannequin as shown at left. The control group completed a traditional septic shock simulation without augmented reality. We administered a pre-study questionnaire to all participants asking about demographic data as well as prior experience with simulated septic shock and augmented reality. We measured the timing and volume of IV fluid administration during a septic shock simulation for all participants. And finally, the PD Sepsis AR group took a post-study questionnaire asking about their thoughts about PD Sepsis AR as an educational tool. We ultimately enrolled a convenience sample of 50 participants, and this was an interprofessional sample consisting of nurses, nurse practitioners. We had multiple levels of physicians, including attendings, residents, and fellows. All of these participants are people who work in the pediatric emergency department. We randomized 25 participants to PD Sepsis AR and 25 to the control group. And we were able to capture the time to 20 cc's per kilo, 40 cc's per kilo, and 60 cc's per kilo in 100% of participants. Of note, there were 4 participants in the control group who chose not to give the full 60 cc's per kilo. In other words, they gave up to 40 cc's per kilo and they decided to stop. So for those participants, we just excluded the 60 cc per kilo data point. On the post-study questionnaire, 92% of PD Sepsis AR participants reported that the application enhanced their awareness of patient blood flow. So our conclusions are as follows. We were able to successfully create an augmented reality application for septic shock simulation, and we also met our feasibility endpoint. We do believe, based on our results, that this is a promising educational tool that's worthy of future study. In the future, what we hope to do is create a more nuanced augmented reality model of a shock state. We hope to be able to depict different types of shock as well, perhaps cardiogenic shock. And therein, we can use augmented reality to teach people how to recognize different forms of shock. So these are my references, and I thank you for your time.
Hello, I'm Dulce Gonzalez. I'm a Pediatric Emergency Fellow at Arnold Palmer Hospital. Today, I will be discussing the effects of a global pandemic on pediatric trauma seen in a Level 1 trauma center. I have no disclosures. First, I would like to thank and recognize all my co-authors and mentors for their help during this project. Traumatic injuries are a common reason patients are brought into the emergency room each year. A 2015 study reported that over 8 million visits to pediatric emergency departments across the US are due to injuries and or poisoning. The National Trauma Data Bank report that the top 3 mechanisms of injury of pediatric trauma are falls at 34%, motor vehicle traffic collisions close to 24%, and struck by or against an object are close to 10%. In our pediatric emergency room, prior to COVID, we were seeing greater than 55,000 emergency room visits per year. 1,000 of those were traumas, and up to 300 were trauma alerts, the highest severity in trauma classification. On March 11th of 2020, the WHO declared a global pandemic by the coronavirus. On March 13th, a state of local emergency was declared in Orange County, Florida, where our hospital is located. On March 20th, a curfew was started, and on April 3rd, a stay-at-home executive order. May 4th, the first phase of lifting the stay-at-home order began. Therefore, we set out to describe the characteristics of pediatric trauma during a global pandemic with mandatory quarantine. We performed a serial cross-sectional observation study in which we collected data from all pediatric visits in our Level 1 Trauma Center. We looked at the volume of patients, the volume of pediatric trauma, mechanism, and severity. Our study period was from March 13 to May 17, 2020, in comparison to March 13 to May 17, 2019, when no such pandemic existed. This graph takes a look at the overall pediatric emergency room volume. We looked at the data biweekly. Blue is 2019 and red is 2020. Prior to the last 2 weeks of March, we saw that the volumes were very similar in 2019, 2020, and we start to see a decline at the last 2 weeks of March with a more significant decline in April. Overall, from March 13 to May 17 of 2019, there were 10,630 emergency room visits, while in March 13 to May 17, 2020, this volume decreased by more than half to 4,244 visits. This next graph looks at the pediatric trauma volume. If we look at the last 2 weeks of March and the first 2 weeks of May, we actually see an increase in the number of pediatric trauma in 2020 in comparison to the same time period in 2019. Overall, from March 13 to May 17, 2019, there were a total of 187 pediatric trauma patients, while from March 13 to May 17, 2020, there were 143. Therefore, from our results, we can gather that there was an almost twofold greater odds ratio of encountering trauma during the pandemic lockdown, odds ratio of 1.96. When we compare similar time periods of early 2019 and 2020, we did not see any difference in odds ratio for encountering pediatric trauma patients. With mechanism of injury of spring of 2019, we saw that the most common mechanisms were falls, followed by motor vehicle collisions, and struck by or against an object, which correlates with that 2015 study that I mentioned previously. When we look at spring of 2020, during the pandemic, falls still remained the most common mechanism of injury, followed by motor vehicle collision. But we did see an increase in non-power and powered devices for mechanism, as well as an increase in assault cases. Our studies showed that the mandated quarantine led to a significant decrease in pediatric emergency department volume. However, despite this overall decrease, the proportion of patients presenting with traumatic injuries increased almost twofold. Therefore, our studies suggest that if there is a time period where we have a societal lockdown due to a pandemic or natural disaster, we can expect the proportion of traumatic injuries to be increased despite an overall decrease in volume. And in preparing for this, adequate pediatric trauma support in regards to adequate staffing and adequate resource allocation need to be strongly considered, since injury prevention and disaster readiness are cornerstone when discussing pediatric trauma. Thank you.
Hello, my name is Erin Bell, and I am a fourth-year medical student at Penn State College of Medicine, and I am an incoming PGY1 emergency medicine resident at the University of Virginia. And today I am presenting my lightning oral abstract entitled Chest X-ray Utilization in Febrile Infants 60 Days or Less in the Emergency Department. 1 to 10% of infants in the age range of 60 days or less who present to the emergency department have a serious bacterial infection. An SBI is defined as bacteremia, meningitis, or urinary tract infection. Multiple pathways, such as the Rochester, Boston, Philadelphia criteria step-by-step approach and the Yale observation score, have been studied to determine risk stratification for this age group. Of these stratification tools, the step-by-step approach has been shown to have a high sensitivity and negative predictive value for ruling out an SBI of 92% and 99% respectively. Furthermore, a chest X-ray for febrile infants in this age range without respiratory symptoms is not indicated, as it does not provide useful information to the evaluation of an infant. Given the concern of radiation hazards in infants and children, measures to reduce the amount of radiation exposure are appropriate. This is a quantitative study to evaluate if the implementation of an evidence-based clinical pathway would decrease the chest X-ray utilization rate at our institution. So this study is a retrospective chart review that included all patients between the age of 0 to 60 days who presented to the ED of a tertiary care children's hospital for evaluation of fever. Charts reviewed were from September 2015 to June 30th, 2019. The baseline data was September 2015 to August 2016. The pathway was implemented itself in September 2016. A chi-squared was used to determine the relationship between receiving a chest X-ray before and after implementation of the pathway. Prior to the pathway, the workup of a febrile infant was medical provider dependent. This slide shows the current pathway for the workup of a febrile infant. Infants with a fever of 38 degrees Celsius by any modality, either observed or reported, were included in the study. We defined respiratory symptoms as a respiratory rate greater than or equal to 60 breaths per minute, hypoxia less than or equal to 91% in room air, cough, increased work of breathing, which is defined as retractions, nasal flaring, head bobbing, and grunting, and focal lung findings in the physical exam. For patients with a fever without respiratory symptoms received a chest X-ray, we identified non-respiratory symptoms that were present. Results. Baseline data consisted of 44 patients with a chest X-ray utilization rate of 57%. The post-pathway implementation consisted of 144 patients. 42 received a chest X-ray with non-respiratory symptoms and 102 with respiratory symptoms. The chest X-ray utilization rate was 29%. Table 1 describes the frequency of respiratory symptoms. We found that the application of the pathway demonstrated a statistically significant decrease in the chest X-ray utilization of febrile infants with no respiratory symptoms. Table 1 describes the frequency of respiratory symptoms in febrile infants. Of the 102 patients, 142 respiratory symptoms were described. Cough was the most common respiratory symptom at 61%. In this study, we demonstrate that utilization of a clinical pathway, which specifically focused on stratifying respiratory versus non-respiratory symptoms, significantly decreased the chest X-ray utilization rate of febrile infants at our institution. This not only minimizes unnecessary radiation exposure to infants, but can provide an opportunity to provide cost-effective patient care. Risk stratification for an SBI in this age range does not have a sensitivity of 100%, but has been shown to have good negative predictive value. The step-by-step approach has better sensitivity and NPV, thus improving this potential. This reveals the opportunity to implement pathways based on current evidence-based practice to safely decrease the amount of clinical testing, especially for vulnerable young infants. The results of the study showed that implementation of a clinical pathway demonstrated a statistically significant decrease in the chest X-ray utilization rate of febrile infants without respiratory symptoms, from 57% to 29%, with a p less than 0.05. Standardizing care by making use of a clinical pathway can help risk stratify patients and result in less practice variation in the utilization of the chest X-rays in the workup of a febrile infant. These is my references. Thank you very much.
Hi, thank you for having me today. My name is Katie Keene. I'm a Pediatric Emergency Medicine Fellow at Morristown Medical Center in New Jersey. I'm here to present our abstract, Shifting Trends in Emergency Department Pediatric Psychiatric Visits After the Arrival of COVID-19. I have no disclosures, so let's get started. In March of 2020, COVID-19 arrived to the New York metropolitan area. As our COVID cases skyrocketed to be some of the highest per capita in the nation, like many other emergency departments, we experienced a marked decline in our overall total volume of ED patients and visits. So we attributed this sharp decline in our volumes to the recent social isolation mandates and quarantine mandates and the general fear that people had in coming to the emergency department and potentially being exposed to COVID. So all this fear and anxiety surrounding COVID-19 and all the mandatory quarantine guidelines and potential exposures and closings of school and work and businesses likely led to these feelings of isolation from your friends and families and peers, and job disruptions and potentially increased family tension from everybody being home. So as the pandemic continued, especially in the pediatric world, we became acutely concerned about the potential negative adverse effects of this pandemic that would have on the mental health of children. So how were they dealing with this total disruption of their normal life and sort of shifting away from all of their normal routines and structures and social outlets and all of these things just being completely taken away from them, except for their video games? So a recent CDC study showed that compared to 2019, the proportion of ED mental health related visits in 2020 had actually increased for children aged 5 to 21 years of age by about 31%. The goal of our study was to determine whether the proportion of ED visits for depression and or suicidal ideation or attempts specifically and anxiety had changed after the arrival of COVID-19. So we performed a retrospective cohort study using the data from 28 emergency rooms within 150 miles from New York City. These hospitals were variable in size and total volumes and were scattered throughout the region. We looked at consecutive patients aged 5 to 21, looking from April 1st to October 31st in 2019 and 2020 respectively, and using April 1st and April as the first full month of COVID-19 in our area. That's why we started with that. So the number of patients in 2019 and 2020 with depression and suicidal ideation and anxiety, we identified those using our ICD-10 codes for those specific diagnoses. We found the proportion of these visits to the total ED visits and calculated that for our patient population between 2019 and 2020, and then also calculated the changes in these proportions for those respective years. So what we found was there was over 1.5 million total ED visits within our patient range. Within our patient database. We had 196,000 visits for patients aged 5 to 21. Over 4,000 of those were for specifically depression and suicidal ideation and or attempts. And over 1,800 patients had a diagnosis of anxiety. So looking at our table and kind of breaking it down between our two specific diagnoses that we were looking at, the median age between both of them were about the same, 16 and 17. There was also a female predominance for that, slightly, about 60% for both of them. As expected, overall, we had more visits in 2019 versus 2020. However, when we calculated the relative change in the proportion of those visits from 2019 to 2020, we found that there was a really significant increase in the percentages for both of our diagnoses. Specifically for anxiety, we found that there was a 36% increase in that proportion of visits. And for depression and suicidal ideation and or attempts, it was a 53% rise or increase in that proportion of visits that we were seeing, which is pretty staggering. So we concluded the proportion of those ED visits for depression and suicidal ideation or attempt and anxiety had definitely increased for children aged 5 to 21 years of age following the arrival of COVID-19 in our area. So these results also corroborated the previous CDC study that was finding that proportion of those ED mental health related visits in 2020 had increased by 30%. So in essence, we were really seeing those adverse effects of the pandemic firsthand and seeing those adverse effects on the children firsthand from this study. So that's what we have. Thank you so much for your time and attention. And that's it.
Good afternoon, everyone. My name is Simin, and I'm a final year medical student at the Yong Loo School of Medicine, National University of Singapore. It is my pleasure today to present our work titled Radiation Dose for Computed Tomography of the Brain in Pediatric Patients at the Emergency Departments. Our study team has got no relevant disclosures. It is well known that computed tomography is associated with a risk of cancer development, especially in the pediatric population, with an established increased incidence of radiation-induced leukemia and brain tumors. Hence, there are recommendations for pediatric dose reduction from the as low as reasonably achievable and image-gently campaigns to the establishment of the size-specific dose estimate from the American Association of Physicists in Medicine. Despite these efforts, literature reported that compared to pediatric centers, children at non-pediatric hospitals received twice the dose of radiation for CT scans performed. Given these gaps in clinical practice, the primary objective of our study was to compare effective doses used for pediatric CT brain studies between pediatric and general emergency departments and determine the proportion performed within the reference levels recommended by the International Commission on Radiological Protection. Our secondary objective was to propose a diagnostic reference level for pediatric CT brain studies performed in the EDs, which is currently lacking in Singapore. Our study is a retrospective study carried out in a healthcare network consisting of 1 pediatric ED and 3 general hospital EDs. Pediatric patients less than 16 years old with CT brain studies performed between 1st January 2015 and 31st December 2018 were included. Information on demographics, diagnoses, volume averaged computed tomography dose index, and dose length product were collected. In total, there were 479 pediatric patients with CT brain studies performed, of which 79.1% and 20.9% were performed in the pediatric ED and the general EDs respectively. 60.5% were males, the median age was 7 years old, and the top 3 diagnoses requiring CT brain studies were seizure, head injury, and altered mental status. When comparing effective doses for CT brain studies between pediatric and general EDs, we found that across all age groups, median effective doses in the general EDs were higher than that in the pediatric ED, reaching statistical significance in those 3 years old and above. If we look at the proportion of effective doses within ICRP reference levels, 48.6% of the total overall CT brain studies fell within ICRP 60 definition. The proportion is significantly higher in the pediatric ED, where 216 were within ICRP 60 definition compared to only 13 in general EDs. When the newer ICRP 103 definition was used, only 2.7% of all CT brain imaging studies were within reference levels, all of which were in the pediatric ED. In terms of the proposed local diagnostic reference levels, based on the recommendations of the National Council on Radiation Protection and Measurements Report 172, as well as the ICRP 103 guidelines, the median volume average computed tomography dose index and dose length product values for each age group may be defined as the local diagnostic reference level. This table reflects the proposed diagnostic reference levels from our study results. It is concerning that effective doses were higher in general EDs than the pediatric ED. What is even more alarming is that none of the CT brain studies performed at the general EDs was within the newer ICRP 103 reference levels. There are several reasons that could have contributed to higher radiation doses at the general EDs. To begin, there are differences in scanning protocols and acquisition parameters of CT scanners used between pediatric ED and the general EDs. Moreover, pediatric protocols are not the default setting at the general EDs. Additionally, radiologists at the general EDs may be less experienced with pediatric CT studies and may modify protocols to increase radiation dose to decrease image noise for better diagnostic accuracy. So how do these results affect clinical practice? We hope that our findings serve as a stimulus for a concerted, nationwide unified approach to pediatric CT dose optimization. Optimal radiation doses should be established by regulatory authorities as national diagnostic reference levels. For institutions, we propose education to raise awareness, as well as implementation of quality control measures to ensure competence when dealing with pediatric patients, especially in centers without dedicated pediatric services. Finally, we encourage frequent reviews of pediatric CT protocols to prevent unnecessary radiation exposure. To conclude, all the EDs should adopt strategies to justify and optimize the use of pediatric CT studies by adopting imaging protocols with reduced radiation doses based on national or local standards. This will allow for better quality management in pediatric CT imaging, making it safe for every pediatric patient in the ED. Thank you.
Hello, my name is Umbra Akbar. I'm a third-year medical student attending the Medical College of Georgia. Today I'll be presenting our study, The Addition of Mid-Thigh Circumference Improves the Predictive Ability of Broselow Tape Weight Estimation. I'd like to thank our entire research team listed on this slide for their time with this study. I have no financial disclosures. The Broselow tape was developed in the 1980s to be a simple and accurate pediatric weight estimation tool based on a child's height. It is used widely in pediatric emergency departments and by EMS to estimate weight and direct weight-based treatment in pediatric patients. The Broselow tape has been found to be accurate in smaller, shorter children, but often underestimates weight in obese, older, and taller children up to 12 years old. Obesity prevalence in children and adolescents has been increasing from 1999 to 2016 from 13.9% to 18.5%. With an increase in obesity prevalence, the Broselow tape's weight estimation accuracy has been brought into question. The objectives of our study were to improve the accuracy of the Broselow tape's weight prediction by employing a second measurement into the weight prediction model and comparing and standardizing methods for measuring mid-thigh circumference. The hypothesis of our study was that adding mid-thigh circumference to the Broselow tape weight prediction model improves its accuracy in weight estimation. This was a prospective observational study conducted in a pediatric emergency department of a tertiary care children's hospital. For our participants, the inclusion criteria included children less than or equal to 12 years old presenting to the pediatric emergency department. Their heights ranged from 45.9 to 143.5 centimeters because this height range met the Broselow tape height guidelines. The exclusion criteria for our participants were children for whom obtaining the mid-thigh circumference and other relevant measurements would interfere with standard of care treatment. In order to build our weight prediction models, we had to obtain different variables. One of those was the mid-thigh circumference, or MTC. We had two methods of obtaining MTC. The first was MTC1, which was the visual approximation of the thigh midpoint for each child by the researcher. And the second was MTC2, which was the CDC-defined method of obtaining thigh midpoint. The way to obtain this, as you can see from the picture to your right, was to find the midpoint between the measured distance from the inguinal crease to the superior aspect of the patella. We also obtained the length for children who were recumbent, or the height for children who were able to stand on a height scale. We obtained the Broselow tape weight, which was the weight of the child given by the Broselow tape based on the child's height. And we also obtained the child's actual weight upon admission to the pediatric emergency department. We used multivariable linear regression to build our weight prediction models, and we used length and MTC measurements as predictors of actual weight in these models. To assess the predictive ability of the models, we used root mean squared error and adjusted R-squared. The three models were, the first was just the Broselow tape. The second was MTC1 plus the Broselow tape, which was looking at the visual approximation of MTC. And the third model was MTC2 plus Broselow tape, and this was the CDC-defined method of MTC. In our results, we were able to obtain a sample size of 430 children, and the data was collected between July 2019 and February 2020. Our age distribution of our sample was 52% of our sample was less than 2 years old, and 48% was greater than 2 years old. 46% of our sample was female, and 54% was male. The race distribution was that 58% of our sample were Black or African American, 32% were white, and 10% were denoted as other, which included children who were Asian, Hispanic, American Indian, or Alaskan Native, or mixed race. We found that all models in our study were significant with a p less than 2.2 times 10 to the negative 16. And in order to assess the predictive ability of the model, the models that had a larger adjusted R-squared and a smaller RMSE were shown to have better predictive ability. So we saw that all ages and in the group greater than 2 years old, for these groups, both MTC and Broselow tape models performed better than the Broselow tape only. We also found that between the two MTC models, MTC2 performed slightly better than MTC1, and this was especially true for the group of children greater than 2 years old. As you can see on the table, the larger adjusted R-squared for the MTC models of 0.85 and 0.87 compared to the 0.61 adjusted R-squared for the Broselow only model, and seeing that the RMSE was smaller for MTC 1 and 2, so 3.1 and 3.03 compared to 5.27 for the Broselow only model. In conclusion, we found that our hypothesis was supported by our data. Inclusion of mid-thigh circumference with the use of the Broselow tape resulted in a more accurate weight prediction, especially in children over 2 years old. We also found that the MTC obtained using the CDC-defined method, which we denoted MTC2, was a slightly better predictor of actual weight than visual approximation. These were our references. Thank you so much for your time today. If you have any questions, this is my contact information on the slide.
Hello, my name is Dana Lebov, and I'll be presenting the abstract for Retroscope 2020, evaluating pediatric 72-hour return rates between pediatric and general emergency departments. I would like to thank those listed below for all their contributions to this work. "72-hour emergency department revisits is a frequently used metric for quality and payment in emergency medical care. There is limited existing data comparing the frequency of ED return visits for pediatric patients by facility types. In this study, we hypothesized that the rate of 72-hour return visits for children is greater in general emergency departments than pediatric emergency departments. We utilized the administrative billing and coding database from a large national emergency medicine staffing group for this study. All pediatric patients, those less than 18 years of age, that were discharged from an ED between 2016 to 2019 were included for analysis. Exclusion criteria included visits that occurred less than 1 hour from the previous visit and those missing an ESI triage level. Associated visit level and facility level characteristics analyzed in the model included age, ESI triage level, gender, insurance type, diagnostic category, facility type, facility size, calendar year, and month of visit. Diagnostic categories were defined using the AHRQ clinical classification software for ICD-10 diagnosis codes. The outcome variable analyzed was 72-hour return visits to the same site, which included both return visits that were discharged and return visits resulting in a hospital admission or transfer. These returns were analyzed at the visit level using descriptive statistics and logistic regression to adjust for potential confounders. A total of 2,274,210 pediatric patients were included across all EDs. Of these, 1,908,429 were across 137 general EDs and 815,781 across 7 pediatric EDs. The proportion of children returning to the pediatric ED within 72 hours was higher than to a general ED, 3.6% versus 2.4% listed above. When adjusted for potential confounders, the adjusted odds ratio for a return visit was 1.31, with a confidence interval of 1.15 to 1.48, suggesting the adjusted odds of representation within 72 hours is 30% higher for children presenting to a pediatric ED than those seen at a general ED. Pediatric patients presenting to pediatric emergency departments are approximately 30% more likely to return to the same site within 72 hours when compared to general EDs after adjustment for confounders. It is not clear if this represents a genuine difference in quality or just a difference in practice pattern. For example, do general emergency department physicians order more tests in the initial presentation? Additionally, a limitation of this study is that it did not take into account patients representing to a different site, which may be a confounder. However, the aforementioned surprising result needs further investigation to be able to determine best practices and improve care in all ED settings. Listed are the references. Thank you for your time.
My name is Thomas Christopher. I'm a third-year Pediatric Emergency Medicine Fellow, and the title of my project is A Pilot Study Testing Intranasal Ketamine for the Treatment of Procedural Anxiety in Children. I have no disclosures to report. Identifying non-invasive ways to deliver medications for pain control, anxiolysis, and procedural sedation is becoming increasingly important, especially in the pediatric emergency department setting. There is growing literature to show that ketamine, which is an NMDA receptor antagonist commonly used for procedural sedation, analgesia, and anesthesia, may also be useful in the treatment of procedural anxiety. However, this is mainly in the preoperative anesthesia literature. Our study aimed to evaluate if intranasal ketamine is safe and effective for the treatment of procedural anxiety in pediatric patients undergoing laceration repair. We conducted a pilot study of pediatric patients seen at our institution for laceration repair from November 2019 until December 2020. Patients were enrolled if they required pharmacologic anxiolysis for the completion of laceration repair. The primary objective of our study was to evaluate if intranasal ketamine will provide satisfactory anxiolysis based on changes in their MyPass short form or modified Yale preoperative anxiety scoring short form scores. The secondary objectives were a 5-point sedation scale, parental and provider satisfaction surveys, adverse events, tolerability, and vital sign changes, and length of stay. Pediatric patients aged 2 years and older weighing less than or equal to 40 kilograms were eligible for inclusion. They had to be presenting to our pediatric emergency department with simple lacerations and had to require pharmacologic anxiolysis for laceration repair. The need for pharmacologic anxiolysis was defined as a MyPass short form score of 30 points or greater, and simple lacerations were defined as requiring 2 or more sutures 5 centimeters or less in length and not requiring a consult service for repair. The patients received 5 milligrams per kilogram of intranasal ketamine to a maximum dose of 200 milligrams 20 minutes prior to the procedure. They also had topical LET gel applied to the lacerations at least 45 minutes prior to the procedure. We documented the patient's age, their MyPass short form scores prior to and during the procedure, a 5-point sedation scale during the procedure, the location and length of the laceration, and number of sutures required, adverse events. We documented vital signs at 5, 15, and 30 minutes, including heart rate, respiratory rate, blood pressure, oxygen saturations, and end-tidal CO2. Length of stay, if they required any further anxiolytic or sedative medications, and the parental and provider satisfaction surveys. This is an example of the MyPass short form, which is a quick anxiety score based on activity level, vocalizations, emotional expressivity, and state of arousal, with higher scores being more indicative of higher anxiety levels. This is an example of the 5-point sedation score with patients rating from agitated to asleep. Patients who remained agitated were classified as not being successfully sedated. This is an example of the parental and provider satisfaction surveys, which asked how satisfied were you with the procedure, then the child's anxiety level, and if the patient or your child required a similar medication in the future, would you want them to receive the same medication? We were able to enroll 25 patients during this time frame with a mean age of 61 months and a mean weight of 21 kilos. The lacerations were mostly located on the head, face, and chin in 84% of the patients, but also 3 on the extremities and 1 on the groin. The lacerations range from 1 to 5 centimeters with a mean of 2.1 centimeters. 92% of the patients were less anxious during the procedure. Patients were rated as calm or drowsy i.e. a successful level of anxiolysis in 80% of the patients. 5 patients remained agitated. Patients that were not successfully sedated tended to be younger, with a median age of 30 months versus 70 months. A decrease in anxiety levels overall was observed from pre-procedure to inter-procedure, with a median of 66.7 to 33.3, which is almost a twofold reduction in anxiety levels, which was statistically significant. 92% of caregivers reported that they were highly satisfied with the hospital experience and their child's anxiety level, and 84% would want their child to receive the same medication in future procedures if needed. 84% of providers were satisfied with the overall procedure, 76% were satisfied with the anxiety level, and 84% would want to use the same medication in future anxiety-provoking procedures. All patients had the procedure completed without the need for any further anxiolytics or sedatives, and all patients were able to be discharged home from the ED. 2 patients reported bad taste, 2 patients reported nausea, vomiting, visual disturbance, and nystagmus, and 1 reported dizziness. No patients experienced any significant vital sign derangements or adverse events, which we classified as emergence phenomena or laryngospasm, for example. The higher success in older patients is multifactorial. Likely younger patients have an increased metabolism and also are less likely to understand directions on how to inhale the medication. In conclusion, we feel that intranasal ketamine at a dose of 5 mg/kg is safe and effective, but future studies are needed to determine optimal dosing and then to compare it to intranasal midazolam. That concludes my presentation. Any questions?